Hello, everyone. This is Marwan Shinawi. I'm a clinical geneticist with the Washington University School of Medicine in St. Louis, Missouri. The title of my talk today is on clinical and genetic aspects of TBRS. Let me start sharing the slides with you. And I'm gonna divide my talk into two parts. The first, I'm gonna present two cases or the clinical history and the genetic results of two of my patients with TBRS that I follow here at WashU. And the second part, I'm gonna go over the clinical and genetic information that we currently have on this condition. So let's start with the presentation on the two patients. So the first patient is now 14 years of age, and that he was initially evaluated in infancy for decreased muscle tone, delayed milestones, large body size and large head size, and some facial differences. He was born after an uncomplicated pregnancy as full term, and in late infancy, he started exhibiting delayed motor and language milestones, and later on, he was noted to have learning difficulties, which he continues to have. And for which all of these he receives therapeutic services. His formal evaluation revealed moderate intellectual disability. Now he speaks in short sentences and participates in social situations, and he is described as very friendly. The patient is now in 8th grade, but he attends 100% of the time special education classes, and he gets mainly life skills. He has an IEP in place and receives therapies through school. His past medical history is significant for 2 episodes of febrile seizures and repair of hernia and descended testes. He underwent placement of ear tubes because of history of recurrent ear infections. In addition, he underwent removal of tonsils and adenoids because of abnormal sleep study. In fact, he continued having issues with breathing during sleep, or what we call obstructive and sleep apnea later on. And this is the reason that he required the CPAP. He follows with orthopedics for flat feet, and his brain MRI showed Chiari malformation. His family history was unremarkable. He has two healthy siblings and two healthy parents. His physical exam around the age of 13 revealed a large body size. As you can appreciate here, he has his weight, height, and head size above the 99th percentile. He exhibited some facial differences, including coarse facial features, bushy eyebrows, deep set and down slanting eyes. He had flaring nares, long and smooth philtrum, thin upper lip, big upper incisors, and the ears were with posterior rotation, and he had a broad forehead. In addition, he had hyperflexibility in the joints of his hands, mild generalized hypotonia or decreased muscle tone. He had excessive hair on his back and low posterior hairline, as well as flat feet. And you can appreciate here these pictures around the age of 7 to 8, some of these changes. As you can see, he had what we call down slanting eyes, deep set eyes, the thickening of the eyebrows, the broad forehead, the incisors, the large incisors there. And the second picture was taken when he was 13 years of age. Again, you can appreciate the large body size, the large head size, what we call macrocephaly, the deep set eyes, and the down slanting eyes here. Another thing that you can notice here, this is what we call a smooth philtrum. In the broad forehead, you can appreciate better in this picture. We evaluated the molecular evaluation was through what we call exome sequencing, which is kind of whole genome molecular analysis. And that testing revealed a missense variant, which means a change of amino acid arginine at position 882 to histidine. To confirm that this mutation is not really limited to just the blood, we did it also on buccal swab as well as on skin, and confirmed that this mutation is found in all cells of his body. Because of the association of this specific mutation at the time with different types of tumors, especially with leukemia, we recommended actually to do blood count with differential every 12 months. And we enrolled him into the study of Dr. Timley at WashU, and he's undergoing genome molecular analysis on yearly basis. The second patient is now about 4 years of age. She was evaluated at the age of 4 months because of decreased muscle tone, delayed milestones, and facial differences. She was born full term, large for gestational age after a pregnancy complicated by gestational diabetes. At 20 months of age, she started exhibiting motor and language delays and started receiving therapeutic services. She saw cardiology for atrial septal defect and pulmonology for central sleep apnea and concerns for aspiration. She saw orthopedics as well because of mild scoliosis, and the eye doctor for astigmatism. Her physical exam, when I saw her at the age of 20 months, revealed a weight at the 37th percentile and height at the 70th percentile. The head size was large at the 95th percentile. She exhibited also some similar features to our first patient, with coarsening of the facial features, deep set eyes, down slanting eyes, epicanthal folds, short antiverted nose, a small jaw, and thin tinted upper lip, as well as deep narrow philtrum. I'm going to show you some of these on the next slide. And she also had hyperflexibility of the knees and decreased muscle tone. And you can appreciate here the similarities between these two patients, which you can see on the right. This is a family picture for the two families that when they came to WashU for the annual evaluation. Again, this is what I mentioned, the narrow deep philtrum, the short nose, the down slanting eyes, the thick eyebrows, the broad forehead. We got an update around the age of 4. She continues having significant central sleep apnea, no change in her umbilical hernia. Her left foot started turning in and the orthopedics actually noted tight Achilles, for which she started receiving orthotic braces. She walks very short distances with a walker, but would need a wheelchair for long distances. She has difficulties with using utensils, and she can say 30 words and use 20 signs. Her evaluation also was using exome sequencing and revealed the exact same mutation that we discussed before at position missense mutation, a change of amino acid arginine at position 882 to histidine. And because of that, we had same recommendations for her to have a blood count and differential every 12 months, and we enrolled her into the Dr. Timley's study. So the second part of my talk is to discuss with you the main clinical features and genetic information about TBRS, which is known also as DNMT3A overgrowth syndrome. So initially, this condition actually was described in 13 patients with intellectual disability and overgrowth in 2014. But now we're aware of at least more than 100 patients who were reported in the medical literature, but from communication with other physicians, we believe that this is way more common than what it was reported. Maybe there are at least 200 individuals now diagnosed with that condition. It is caused by either de novo most of the time or inherited mutation in a gene that we call DNMT3A. Each individual carry a genetic variant in one of the two copies of that gene, and it's important to understand. But this is found in all the cells of the body individual of the patient. And this is just illustration of the variety of the mutation that were documented. This is a cartoon showing the structure of the gene. And the black boxes, actually, these are the important domains or parts of the gene. And you can appreciate how the mutations are actually clustered, located mainly on those important domains. Most of the mutations are what we call missense variants, which means a change in one amino acid to another amino acid. This is not considered usually a big change, but in reality, this definitely would change the function of the protein. And here is the location of the mutation that I mentioned, which was found in my two patients at position 882. The arginine was changed either to histidine or in other patients to cysteine, amino acid cysteine. And this is the estimation now that this mutation is one of the most common ones, and it's found in about 15% of the patients. In the lower part of the cartoon, you can see that there are other types of mutation. This is sometimes we have what we call a stop gain mutation or frame shift mutation or end frame deletion. These usually are more disrupting for the structure of the gene, but also can lead to functional abnormalities in the gene. So this is important to discuss with you also the inheritance or genetics of TBRS. It's inherited in what we call autosomal dominant manner. And this is related to the fact that one of the two copies has to have the mutation that we mentioned before. So the pathogenic variants, or the other terminology that we use, the mutations in this gene, are brand new changes, are not found on the parents in about 98% of the cases, or can be inherited. And I cited here two articles indicating that these mutations can be passed from one parent to the child. And this is the minority of cases, 2% of the cases. If neither parent of a patient has TBRS with negative genetic testing, the risk to SIPS of the patient is low. It's around 1%, but the risk to children of affected individual is 50%. Let's talk about the clinical findings. So as you notice, the most common clinical finding among patients is delayed milestones as well as intellectual disability, almost found in every patient that was documented in the literature. But the spectrum of severity is broad. This can go from mild to severe intellectual disability, but the majority, in fact, exhibit moderate degree of delays or intellectual disability. Interestingly, their verbal abilities better than nonverbal skills. The majority of patients exhibit what we call impaired adaptive functioning. These are the daily life activity. This is the reason that many of them would require assistance at school, assistance at home, and when they get older, they would require the support of their parents. More and more we realize maybe there is some neurodevelopmental regression, but again, this is not, it was documented just in a few cases. lower intellectual ability and lower scores in adaptive functioning correlates with more severity in the autistic traits. Almost all patients require high level of support in school or at home. And when they get older, they would require living support from adults. Behavioral and psychiatric problems are found in about 50% of patients, and this would include autism, anxiety, aggressive outburst, ADHD, psychosis, schizophrenia, and bipolar disorder. Autism is found in 30 to 50% of patients with TBRS. The second clinical finding that I'm going to discuss with you, this is overgrowth, which is found in 85% of patients with TBRS. Remember, this is not all patients. Actually, the second patient that I presented today did not have, by definition, a overgrowth, at least in the height and hair weight. So there are different definitions how we can define overgrowth. One definition is this is height and or head circumference or head size that is equal or greater than 2 standard deviation above the mean. Obesity is also common among patients and is found in about 2/3 of patients with TBRS. Many patients are born, in fact, with a large for gestational age or overgrowth. There are facial differences in most patients, as you can appreciate here. So the face can be long or round. Most patients have what we call a broad forehead, as you can appreciate here. The thickened and eyebrows, you appreciate here in many patients. Large upper incisor, it's very clear also in my first patient. Coarsening of the facial features. By the way, most of these are really more cosmetic issues. Usually they don't have any functional significance. Deep set eyes, sometimes down slanting eyes, and the philtrum can be different, either smooth or deep. Sometimes the patients also would have what we call thin upper lip. Additional common clinical features include decreased muscle tone, joint hypermobility that can involve small joints like in hands or large joints, as in my second patient in the knees. A umbilical hernia, as you can see here. Cardiac anomalies are found in about 1/5 of the patients, and most patients actually have congenital heart. Most patients with cardiac anomaly, these are really congenital. Patients would exhibit recurrent infections in the sinus and their lungs. More and more, we realize that many patients have what we call autonomic dysfunction. So this would include, for instance, changes in the blood pressure when they transition from sitting to standing position, what we call postural orthostatic hypotension, or changes in the color of their skin because of the vascular instability, or they would have a poor heat tolerance or decreased sweating or high pain tolerance, or even the central sleep apnea is attributed to that, although there can be other factors. Additional common findings, these are seizures, which is found in about 1/4 of the individuals with or without fevers. Brain imaging is generally normal but non-specific, and this would include large ventricles or what we call Chiari malformation. Orthopedic problems, you can see that this is becoming an item that we focus on when we evaluate any child with TBRS. This would include scoliosis, kyphosis, tapering fingers, foot anomalies and toe anomalies. This can go from, this is the scoliosis that I mentioned, flat feet, but also other types of foot anomalies and descended testes. This is a hot topic in the field of TBRS, the association between TBRS and malignancy. Why we're making a big deal of that? Because somatic mutations in this gene, which means mutations that are limited to blood, are found, or to another tumor tissue is limited to that tissue. Those patients are not born with this mutation. They develop, actually acquire this mutation over time. And this is kind of sequence of events that ultimately would lead to the tumor. And in fact, in certain types of leukemia, the mutation, the most common mutation, is the mutation that I presented on my first two patients. So there were several reports of association between leukemia, and I have citations here for different articles doing this association between leukemia, neuroblastoma, ganglioneuroblastoma, lymphoma, different types of brain tumor. The estimation now that malignancy is found in about 7 to 7.5% of the patient. Despite this fact, we don't have actually surveillance protocol at this time. So the question, how we can establish a diagnosis for TBRS. So there are two cardinal features, as you noticed. These are the overgrowth and the intellectual disability. These are required to make a diagnosis. But as indicated previously, if overgrowth is found in only 85%. This is the reason that we have also additional finding that we call supportive findings. So these are all the clinical manifestations that I mentioned before. In addition, we need actually a molecular confirmation of what we call a mutation or pathogenic variant in the DNMT3A gene. Why is that? Because there are many other conditions with overgrowth and intellectual disability that can mimic TBRS, such as Sotos syndrome. So this is my last slide, but this is a really important slide. I would like to acknowledge all the families who shared the clinical information as well as the photographs on the patients that I presented here, but also on what was presented in the literature. And the whole medical community is highly appreciated. Thank you so much.